And I'll hand out Scantrons for that when we're done. I think it's like 20 questions, multiple choice, same as usual. So pediatric airway considerations. If you guys had to take a wild guess, what are the leading causes of cardiac arrest in pediatric patients?
Respiratory.
Respiratory issues, right? What's the leading cause of cardiac arrest for adults?
Cardiac.
It's essentially arrhythmias, acute myocardial infarction, ACS syndrome. There's a section where it turns into trauma, but it's largely cardiac related. With kids, it's almost universally respiratory issues. So foreign body airway obstruction or like a pulmonary infection that just creates more and more hypoxia. And their pathway to death is almost universally shortness of breath, a hypoxic event, hypoxia leads to bradycardia, bradycardia leads to asystole. 99.9% of the time, that's the course, the clinical course of these patients. So we have a real opportunity to try to intervene in that and prevent them from decompensating it further, just by pure virtue of controlling their airway and managing their airway appropriately. So this is the breakdown of their considerations, pediatric airway considerations. What makes pediatric airway management so important? Besides the fact that we want to prevent cardiac arrest, what are some considerations that we have? What's the difference between a pediatric airway and an adult airway?
Tiny.
Giant tongue, giant bulbous tongue.
Their neck mobility and the way that you have to place them.
Okay.
Because their head's bigger, so you
Simply
gotta.
Positioning them. Yeah, their airway, their trachea is. The cartilage rings aren't truly formed yet, so it's more malleable, more flexible. It's softer, smaller airway, smaller lumen. And if you hyperextend the neck because you position them poorly, it's like a coffee straw. You're just collapsing the airway. So we have to be very careful with how we position them. What's the ideal position for us to put them in?
Oh.
Especially very, very young children. Sniffing position, right? So we'll put them in that sniffing position. We'll put the towel roll behind their shoulders, not behind their head, and just try to keep their occiput up a little bit, and really just keep the ear in line with the sternal notch. How about physiologically? So they breathe more often, so the respiratory rate is higher. How about oxygen consumption? Higher, lower, the same? The actual oxygen the body's using. It's like 2 times that in adults, which is part of the reason why they have an increased respiratory rate. Does this look familiar to everybody?
Mm-hmm.
Pediatric assessment triangle. This is your at-the-door assessment of the patient. So you walk in the door before you lay hands on them. You just get a quick little sick, not sick view of them. I really use this tool for I think we all do. We use this for pretty much every patient. You walk in the door and just at-the-door assessment, like how does the skin look? How does the cognition appear to be? How does the circulation look? What does their work of breathing look like? We're just trying to determine whether they're in respiratory distress or respiratory failure. What's the difference between distress and failure?
Distress is working harder, failure is not working at all.
Yeah, failure is where your body's no longer compensating for the amount of work you're putting in. It's like shock. So you have compensated shock versus decompensated shock. Think of distress versus failure as compensated versus decompensated. So we already hit this. The airways themselves are smaller. The epiglottis is long and floppy. The tongue is large and bulbous. These are good things to have in the back of your mind when you're dealing with the pediatric airway, and you'll see it firsthand once we go into the lab. These mannequins are still pretty easy to intubate just because it's plastic, and again, it's a head on a board. It's not a whole body. But you'll be able to see that there's not a lot of room to work with in here. Keep in mind that the airway being smaller means that it's much more easily obstructed. So even a little bit of edema, a little bit of swelling is going to cause a significant problem versus an adult where you can have a sore throat and be perfectly fine. Meanwhile, a kid, they're going to be drooling, look like a bulldog because they can't swallow because their epiglottis is large and they're going to have a really hard time breathing. What is the narrowest point of the adult airway? Glottic opening, right? It's different for pediatric. Remember what the narrowest space is for a pediatric? It's just below that. So it's at the level of the cricoid cartilage. So while the adult airway, we pass the tube through the vocal cords and inflate to create a seal. When we intubate a child, we pass the vocal cords, and it's just below that's the narrow spot. So we won't be able to see the narrow spot, but that's the reason why we don't have to use an inflatable cuff when we're intubating somebody. Once you pass the tube through the vocal cords, it creates an anatomic seal just below the vocal cords. This is what we talked about before with positioning. So the large occiput will allow them to kind of push their jaw to their chest, which will flex the neck and collapse the airway. And if you have an improperly placed shoulder roll, their head will be hyperextended and it'll collapse the opposite direction. So a properly placed towel roll will be just below the shoulder blades, below the occiput. Has anybody ever had to do this?
Mm-hmm.
One or two people? You'll get your chance. It's never fun. So kids, obviously, a couple other different problems. They obviously have a smaller tidal volume. The lungs are much smaller, so that goes pretty straightforward. The respiratory rate is elevated, and their oxygen demand is double that of an adult. So what does that tell us? If they're already hypoxic, if they're having a hard time breathing, they're going to desaturate much faster than an adult will, right? And if they desaturate, what comes next? Hypoxia, bradycardia, and asystole. I think this might be a video. No, not a video. When you assess a patient's chest, you'll never be able to tell if they have retractions, intercostal retractions, unless you actually look. So it's a good idea to unbutton the onesie that the kid's wearing and pull their shirt up and take a look at their ribs and just see if you have any retractions. So you could have intercostal, subcostal, up in the sternocleidomastoids, you'd be able to see some retractions. Just when they're trying to work to breathe, they're using all those accessory muscles. Hey, what's going on, bro?
How we doing, sir?
Best day ever.
Afternoon? Oh, yeah. Good day above ground. It's a good day.
Yeah, that's good. So pediatric assessment. How do you rate these kids? Which one's the sickest?
Hold on.
The one all the way on the right.
The one all the way to the right's the sickest. Where would you put the medium one?
Medium, probably the one vomiting.
Okay. So what makes you say the kid all the way on the right's the sickest?
Not crying, doesn't look like it's really reactive to whoever's taking that picture.
Not passing the look test. Just the kid's consciousness doesn't
Bless
look like
you.
it's all there. Skin color looks questionable. Activities absent. And then the other two kids, that's kind of up in the air. I think I would put the one in the middle probably is sicker than the one all the way on the left because just the color of the skin. The perfusion to the face is absent. So maybe it's just a measurement of them being sick and crying and being a little flushed. But the appearance, when you first walk in the door, that appearance gives you a really good idea as to just how sick this kid is. Gives you an idea as to the severity of the illness and the respiratory, the possibility that this might be a respiratory cause we have to deal with. We already talked about that. Appearance, so we're looking at their muscle, their tone. Are they able to sit upright? Are they able to hold themselves up? Are they being supported by a parent? Are they looking around the room? Are they aware of their surroundings? Are they vocalizing? And if they can't speak, does their cry sound normal? Are they phonating appropriately? Work of breathing. This is a pretty important one, especially for our purposes. Work of breathing is just the amount of work that they're putting into to actually ventilate. So where you need to carefully assess, look for accessory muscle use, positioning. Are they tripoding? Are they just kind of listless and limp? We're going to listen for any abnormal respiratory sounds. So a lot of times you can hear this without a stethoscope just walking in the room. Remember, breathing should be almost imperceptible. You shouldn't notice it. If you notice it, something is probably wrong. And then circulation of the skin. This goes back to the kid in the second picture was extremely pale. Just look to see, are they cyanotic? Are they pale? Do they have good cap refill? What should cap refill be?
Less than 3.
Less than 3 seconds, ideally. No audio.
I was going to say that's the quietest group I've ever heard.
Right? There should be audio with this. treatment cell. So this kid should have a seal bar cough, but like I said before, if you don't take the shirt off to look at this kid's breathing, you're not going to notice that. You're just going to see the kid's limp.
Yeah.
There we go. Remember, infants don't have very defined muscles yet. Their chest wall muscles aren't really there, so when they start having a hard time breathing, they might just grunt, they might just bob their heads. You notice the kids got the nasal flaring too. They're just insanely trying to increase the amount of air they can move. So pretty much all of those things are things that you would not notice if you didn't expose the chest to actually look. So that's why the careful assessment is pretty important. We're going to go through our ABCs just like every other assessment. So airway, we're going to look and see if the airway is actually physically open. What do we have to worry about with kids?
Foreign bodies.
Yeah, foreign bodies, especially young kids, 3 and under. Just anything they find on the floor, they'll put in their mouths. Unchewed food, whatever it may be. We're going to assess the respiratory rate, check their actual work of breathing, check their pulse ox, check their end tidal CO2 if you're feeling fancy. Listen for air movement, see if it's on both sides. You know, document if they have wheezing or stridor or anything like that, any unusual lung sounds. If it's quiet, it's not generally a good thing. What's our target pulse ox? What's our ideal pulse ox? Yeah, 93, 94 or better. Circulation, the information we get from the pediatric assessment triangle is really circulation of the skin, and we're going to come up and actually check a cap refill and make sure they have good return. And then disability for this part is just are they conscious or not? I have to go. So this isn't really a huge surprise, right? A lot of our calls for kids are generally a sick kid, seizure, or a respiratory problem. I feel like respiratory problem is the most common, and it's usually what? What kind of respiratory calls do we get with kids?
RSV.
RSV is extremely common, especially in the winter months. Asthma's huge. We get croup. We don't get a lot of epiglottitis, but you get a lot of croup. You get a healthy amount of croup. And again, no matter what it is, we just want to boil it down to is this respiratory distress, respiratory failure. Where in this category of distress are they right now? Again, respiratory distress is just they're working to breathe, but they're able to compensate for it. So what are some signs and symptoms that you might associate with respiratory distress?
Or use of accessory muscles.
Okay, use of accessory muscles.
Not wheezing.
What's that?
Wheezing.
Wheezing, okay.
Nasal flaring.
Nasal flaring.
Increased rate.
Yeah, absolutely. Increased rates, probably one of the earlier signs. So accessory muscles, increased rate, just a generic increased work of breathing. At what point would you say this is failure?
They become cyanotic.
Okay, so the skin starts to change color because they're not able to get the oxygen to where it needs to be.
Altered mental status too.
Yeah, change in mental status, I think, would be the line was saying. Once they start getting a little tunted, a little confused, like it's no longer distress. This is absolute failure. And then at what point do we call it respiratory arrest?
And they stop breathing.
Yeah, respirations have ceased. We're going to treat pediatrics the same as we are with everybody else. Maybe we'll be a little bit more aggressive with our oxygenation, but we're just going to go ahead with supplemental oxygen, maybe pre-oxygenate as much as possible, put them on the monitor, end tidal, SpO2, get our access as necessary. A lot of our stuff, IVIO is going to be secondary to the airway, always. Manage the airway, and then, again, BLS before ALS, especially with pediatrics. This is a high acuity situation with highly dangerous, low frequency. So don't rush to intubate these people. Like, you're going to practice it here on mannequin, and that hopefully is the first and last time you have to control the airway of an infant or a pediatric.
God willing.
Fingers crossed. So don't rush to ALS. If you can manage the airway using BLS techniques or even a supraglottic. In the Hudson Valley region, we can't do supraglottics in pediatrics. Hopefully that's something that changes in the future. But if you can manage your BLS, don't ruin something good. I covered this already pretty much in depth. Respiratory failure and shock are the most common causes of cardiac arrest in children. There's about 16,000 pediatric cardiac arrests annually, and most of them are from respiratory problems. What EKG rhythm do you think is most common when we get to a pediatric cardiac arrest? When they're already in cardiac arrest. What's the most common rhythm? Are they going to be V-fib, V-tach, V-systole? What did I say before is the pathway for pediatric cardiac arrest? It's probably going to be asystole. It's going to start with respiratory distress, respiratory failure, respiratory arrests. Bradycardia is going to be mixed in there, and then it generally will go to asystole. We're not going to see a lot of shock and arrhythms in pediatrics. And then obviously the outcome for pediatric cardiac arrests, outcomes are generally very poor. With adults they're poor, with pediatrics it's even less. There's studies that show like 30% of kids don't even get CPR because people are just afraid to touch them for whatever reason. A dramatic moment was caught on camera.
I'll be the judge of that.
I appreciate the smoker up front. Ready to the firehouse. How's this? Look out. But this is a very real possibility that these guys, 30 seconds ago, were probably just in the back room watching TV, fucking off, not doing anything productive. And then someone comes up and hands them a child that's not breathing. This could very, very, very easily happen to you when you walk into any one of the restaurants you go to when you're on duty. You just walk into Dunkin' Donuts, grab a cup of coffee, and turn around, and somebody could fling a child at you. So just understand how to open up somebody's airway if they're obstructed.
Notice one guy ran out with 2 bags, and then the other 3 run out with fuck all, with nothing.
Nothing. Hands in pockets.
Yeah.
Probably somebody down with a clipboard. So how do we clear a child's airway? If they are not breathing but responsive, how do we clear their airway? Backslaps? Yeah, remember their airway is shaped like a funnel. So if we can get the head down and just backslaps until the airway is clear, or
Flip the pancake.
flip the pancake, and then we go to backslaps and chest thrusts, backslaps and chest thrusts. And what happens when they go unresponsive? We're just doing CPR. The only thing that we're changing is before we ventilate, we're going to look in and see if there's something we can easily just scoop out of there, right? So responsive infants that are not breathing, backslaps and chest thrusts alternating until you can clear the airway, or until they're unresponsive, and then at unresponsive, it's just CPR. And it's 32 of your single respirator. We have the old forceps, which, has everybody had a chance to use the forceps so far? Has anybody not used the forceps yet? I think there's somebody that didn't have it signed off in their book, but we'll address that later. Yeah, when it gets to the point where nothing is working and you can't ventilate them and you're doing CPR, you might just have to go in there and take a look and see if there's something you can grab. What's the narrowest point of the pediatric airway?
Just past the glottic opening.
just past the glottic opening of the cricoid ring. So it's possible that it's down below the glottic opening. If it's below the glottic opening, we're pretty much SOL. What could you do, realistically? You got a dead child in front of you not breathing. Try to clear the airway. You can't clear the airway. You go with the laryngoscope and you go down. You can see the glottic opening, but you can't see anything else. What are your options?
I'm gonna try the tube because hopefully I can push the whatever it is down.
It's a Lego.
It's a Lego. We're just gonna push the Lego into the lung and let it be the hospital's
It's probably
problem.
a fucking Lego head,
Mm-hmm.
most likely. Yeah. No, absolutely. Yeah. If you can't see the obstruction, there's nothing you can grab. There's nothing you can scoop out or suction out. Just attempt to intubate, and hopefully you can push it into that right main stem. If it's a saddle obstruction and it covers both bronchi, there's nothing even an experienced surgeon will do at that moment. Like, dead is dead. But if you're able to get that left lung ventilated and the right lung is just fucked, they can go down and do a bronchoscopy later. Save that for the pediatric surgeons.
Yep.
Like, I don't want to give you guys a false sense of fear here. Like, most obstructions are, the kid swallowed something larger, and just the head down back slaps usually clears it, 90% of the time. But there's still, we don't train for that 90% of the time. We train for that 10%. We talked about positions already, so head tilt, chin lift, jaw thrusts. If we're dealing with an infant, somebody with a large occiput, we're going to have to do the towel roll. And when you're doing this, just check the obstruction. OPAs, how do we size our OPAs?
Mouth to ear.
Corner of the mouth to the ear. What's the difference between how we put an OPA in a pediatric versus an adult?
Tongue gets in the way more.
Tongue gets in the way more because remember the tongue is large and bulbous and it's floppy and it's in the way. So how do we put the OPA in? How does the textbook say we put the OPA in pediatrics? With an adult, it goes in upside down and you twist it in place, right? With a pediatric, you place it in anatomically, but you're supposed to have a little wooden stick here to hold the tongue down so you can place it in. That's how they've been teaching it for 30 years, and they're not going to change for you. So sizing the OPA is pretty important. If it's too small, it's not going to hold the tongue back, and if it's too large, you just insert an airway obstruction. So make sure you size it from the corner of the mouth to the tip of your lip. Nasal airways. Remember, kids' airways are freaking tiny as it is. So infants, do you think you'd be able to put a nasal airway in there? It wouldn't do a single thing. So once they get into like 2, 3, then you could probably do a nasal airway. But like newborns, infants, they're obligate nose breathers, but there's no way you can get a nasal airway in there. It's just not. The size of the lumen would not be enough to deliver the air. So with a kid, with an infant who's an obligate nose breather, you just have to suction out their nose with like a bulb syringe and get the snot out of there so they can breathe adequately. But you're not going to be able to get an NPA in. Diameter is just way too small. Delivering oxygen to them, I have to have this in here just because blow by. I feel like this is the default for almost everybody. I've never met a kid that was not an extremist that I could slap a mask on. And when they're at the point where they're an extremist and you can put a mask on, you're probably preparing to do something looking more invasive. But blow by is the way to go. Not a breather, they'll handle it. Generally speaking, having mom or dad hold the mask to the kid is generally the best practice. As long as they're not an extremist. If they look like they're circling the drain, you have to get rid of work. Maybe you don't have mom and dad right there. Pop-off valves. A lot of BVMs have this pop-off valve that'll prevent delivery of excessive pressures. So just make sure it's activated so you don't pop a lung, cause a little barotrauma. Don't over-distend the chest. Remember, we're just trying to ventilate just enough to get a little bit of chest rise, and that's it. We're not trying to break any records here. Have you seen Sammy and Kevin yet? Or Stacy and Kevin yet? Not yet.
No. I'm first. What do I win?
What's that?
What do I win? I'm first.
You went an entire class for like,
Yeah.
we're almost there.
I didn't look in the office, so they may very well do that.
Do you want the prize box? All right.
I want to stick my hand in that prize box.
You can go get the prize box. It's okay.
When we're sizing the BVM mask, we want to make sure it's the right size. We don't want to use an adult mask.
Just the
on
gold
infant,
star.
right?
That's all I want.
Almost every ambulance carries a pediatric size, which should have 3 masks, and an adult BVM, which should have 2 masks. So just make sure you select the right one, and just squeeze, release, release, release. So with an adult, sorry, I gave you the adult one. The adult one has 3 releases, pediatrics only 2. Squeeze, release, release.
I was saying that her ball Keely the other day and was backing up for the about you.
I'm so sorry. With who?
Keely,
Oh, right. Was she saying the mantra too?
yeah, we were both doing
It fucking works, right? That's how you time it. I'm telling you. Our advanced airway options for pediatrics. Again, we're gonna talk about supraglottics. You guys are gonna see supraglottics. We might have some here in the lab. I'm not sure if we have the size 0 and size 1s, but again, right now for some reason the Hudson Valley protocols don't have it in there for pediatrics. Some agencies still carry them. I think New Windsor's an agency that carries pediatric sizes, but
What, the masks?
supraglottic airways.
Oh.
That'd be an eye
Oh,
gel?
the
or-
eye gels, yeah.
Okay.
New Windsor and Newburgh both have them.
Yeah, so I don't believe it's in the protocols, so I think there might be a little,
I don't, yeah, it's
So
not,
it can ask for
I don't
forgiveness
know why
later.
we don't have them. They don't carry them in their ALS bags. I don't know why they're there, but they do have them.
oh, they're like in the stations hanging
Yeah.
out? Okay. I bought a couple just for training, just to have in the station, but I haven't rolled them out because we can't, so, not yet. Endotracheal intubation, we know all the advantages and complications. What's the advantage of endotracheal intubation? You own the airway. And what's the disadvantage? You're responsible for it now. That's pretty much it. When we're choosing a blade, which blade do we want to use in pediatrics? Does it matter? What's this one called? Macintosh. How does the Macintosh work? Okay, so the Macintosh goes into the pocket. What's the name of the pocket? The vallecula. And it activates the hypoepiglottic ligament, which lifts the epiglottis so you can see the vocal cords. It's awesome for adults. It works for adults, but that ligament is not really developed yet in pediatrics. So you could go in there all day long and not activate it and not be able to lift up that epiglottis. So we have to use a straight blade. What's this one called?
Miller.
Miller. So the Miller blade, we're going to go in, we're going to directly lift that epiglottis, get it out of the way, and go ahead with the intubation. They do make Macintosh blades, which are size 0 and size 1. Could use it, but if you use it the way it's designed to be used, it's probably not going to fucking work. So you have to lift up the epiglottis directly. How do you size it? How do you know which size to use? Yeah, look for your Broswell tape. Look for your cheat sheet, and it'll tell you everything you need to know. Size of your tube, size of your blade, the amount of stuff you have to draw. Otherwise, it should go from the corner of the patient's mouth to the tragus of the ear. So size it just like you would know PA. But if you're pre-planning, if you're on your way to a call, like, don't be afraid to be that guy on the way to a call to ask for a little bit more information. Like, oh, we're responding out to a 3-year-old not breathing. Okay, give me the patient's known weight, and you can just work backwards on the Broswell tape from there. We got a couple different styles of ET tubes. Why would we want to use them uncuffed? Why is that an option?
The uncuffed one,
Yeah, why is uncuffed an option for pediatrics?
it's just past the glottic opening, that's the most narrow part of the airway for younger kids, so it's just gonna naturally seal itself.
Yeah, exactly. So you get that anatomic seal by using the uncuffed ET tube. There's a push to move towards cuffed ET tube, so you have both options. And there's a little math that goes along with it. So 4 plus the 18 years divided by 4, or 3.5 plus the 18 years divided by 4. These are things you're going to have to know for class to get through tests, but once you're in the field, again, use a Broswell tape, use your cheat sheets, and you'll have it down. How else could you size an ET tube? Are there any anatomic clues you could use?
The size of their,
Look at the size of the pinky, and that gives you a rough guesstimate. That may or may not be accurate. We talked about sniffing position. I don't know why I have 3 slides with the same pictures in it, but more of the same. We're going to try to get in that sniffing position. Ear to sternal notch is pretty ideal. So we got a shoulder roll here. We got a headrest for the younger kid. Older kid, we just have a headrest. We're going to do the same thing we do for everybody else. We're going to try to pre-oxygenate for 3 minutes before we do anything. Make sure try to get their oxygen up to as close to 100% as we possibly can, and then we're going to take their airway. So we have a quick little video of a very well developed video.
To intubate, extend the head but avoid hyperextension, which can obstruct the pediatric airway. Lift the blade with your left hand with the blade facing away from you.
That is a giant blade.
Insert the blade
It's
as
like
far
another
to the right side of the mouth as you can, and then sweep the tongue to the left. Control of the tongue is essential, or you won't have room to pass the tube. Slowly lift the mandible upward as you advance. Be careful to avoid pinching the lower lip between the teeth and the blade as you lift. Continue to lift the
She's
mandible
flopping a little
upward
more than I'd like
until
to
you
see
see
for
the
that
narrow
as a
epiglottis above, the bulges of the arytenoids at the bottom, and the vocal cord stretching between. Be gentle. Traumatic intubations can cause swelling, which can be especially dangerous in the child's small larynx. You can also ask your assistant to hand it to you in the correct orientation for insertion. Hold the pre-selected tube in your right hand like a pencil, curved forward. Keep your eyes on the trachea and maintain control of the blade. Insert it to the right side of the mouth and watch it pass through the vocal cords. Stop when you see the lowest marker ring past the cords. While there may be a blind spot at the moment of entering the larynx, you can often see the arytenoids behind the tube. Carefully remove your laryngoscope blade.
Nice gloves.
Right? I think this predates PPE.
Oh, she's got her internet on.
But the actual airway control method we have here is very similar to the adult. We just need to be careful with the size of the airway and selection of equipment. The key takeaways here are pediatrics have really small airways, short necks, kind of fucked up airways, easy to mess up if we do it incorrectly. So get in that tricuspid position with a shoulder roll behind the head so you can get their airways open perfectly for us to actually view. Watch out for the epiglottis and the tongue, so long and floppy, bulbous, they're just going to be in the way. And keep the nares clear while you're suctioning or bisuctioning, and avoid hyperextension of the neck. But outside of that, the rest of the airway control stuff is largely the same. So we're going to break off into 3 groups, go into the lab, and we're going to practice pediatric airway stuff. So we'll start at you and